NUR2016 Group 26 Respiratory.
This is patient information on Peter Smith. He's a male, 25 years old. He's currently unemployed. He has a past family history of asthma on his dad's side, and he was diagnosed with asthma since he was 7 years old. He has a younger brother, which also has asthma, and they both had asthma attacks in 2000 and 2014. His current presentation is that he's admitted into ED at 1400 hours due to exercise-induced asthma. The clinical manifestations is shortness of breath, difficulty breathing and speaking, wheezing and tight chest. He has no allergies to any medications. Peter is a non-smoker. He's an occasional drinker on special occasions, 2 to 3 cans. Both his parents are still alive. Peter was playing basketball before he was admitted into ED. After the game, he realized that his asthma inhaler was empty, so he started showing signs of shortness of breath, wheezing and coughing. By the time he arrived in ED, his condition was deteriorating. His observations recorded were respiration 50, heart rate 120, blood pressure 130/75, temperature 38, and SATs were 80. He was given 8-liter Hudson mask to increase his SATs. The doctor prescribed him Montelukast, salmeterol, fluticasone, and salbutamol. The parents gave consent for his treatment. Peter was relocated to the wards for further observations. His conditions were slowly improving.
Asthma is classified as a chronic lung disease that can be controlled and maintained, but it cannot be cured. It consists of having an airflow obstruction, which consists of a resistance to airflow and exhalation difficulty due to inflammation with symptoms such as wheezing, shortness of breath, coughing, and chest tightness, which are common symptoms witnessed with Peter. Therefore, airway obstruction consists of bronchoconstriction, hyperresponsiveness, mucus secretion, and airway inflammation and swelling occurring at the lining of the bronchi and bronchioles. Furthermore, the end result inflammation leads to an increase in smooth muscles, increase in bronchial blood vessels, thickening of collagen layers, and loss of airway elasticity due to further breathing problems. When an asthmatic trigger occurs, there are multiple cells that play a role in the response, including mast cells, neutrophils, eosinophils, and lymphocytes. These cells release chemicals such as histamine, bradykinin, prostaglandin, and leukotrienes, which work as mediators in response to inflammation. The chemicals lead to an increase in blood flow, fluid leaks from vasculature, bronchoconstriction, and an increased movement of white blood cells to the area of inflammation. In the case with Peter, it will be the bronchi and bronchioles. In addition to the inflammation response, bronchospasm occurs due to the airway hyperactivity, which causes further narrowing of the airways that indicates the severity of the asthma in response to the trigger. In conclusion to the airway obstruction, hypoxemia and hypercapnia can develop due to the alveoli becoming hyperinflated, leading to an increase in pressure within the alveoli, causing a ventilation-perfusion mismatch. Concerns regarding Peter is having untreated asthma and airflow obstruction, which can lead to respiratory failure, including hypoxemia and hypercapnia, pneumonia, atelectasis, and status asthmaticus. Furthermore, a complication for Peter in the community is exposure to asthma triggers such as cigarette smoke, allergens, airborne and environmental irritants, certain medications, exercise, and dietary triggers. As nurses, we're mostly concerned of being exposed to cigarette smoke because it causes asthma to flare up, causes a low management of asthma, reduces the body's response to the inhaled corticosteroid, and accelerates decline in the lung function in the long term. Peter was admitted to the ward with high blood pressure, a low oxygen, and high breathing rate, which are factors that appear in patients with asthma difficulties. To counteract Peter's asthma attack and complications, an administration of supplemental oxygen. I am looking at leukotriene modifiers, which is also Montelukast, which was given to Peter. Peter was administered with Montelukast taken as a tablet used to counter prophylaxis and long-term treatment of asthma that can be taken with or without food. However, it must not be administered to Peter if he is hypersensitive to the drug or its components. Peter must be educated on the side effects before administrations and that could possibly occur, including headache, dizziness, fatigue, asthma and fever in the central nervous system, allergic granulomatosis angiitis located cardiovascularly, nasal congestion, nasal discharge, otalgia, otitis, otitis media and tonsillitis, which can occur in the nose, mouth and throat, conjunctivitis and myopia in the eyes, abdominal pain, dental pain, diarrhea, dyspepsia, infectious gastroenteritis, nausea and pancreatitis in the gastrointestinal, pyuria located gastrourinarily, aggressive behaviour and altered behaviour, which is a psychiatric concern, and elevated ALT and AST levels in the hepatic system, cough and laryngitis in the respiratory system, atopic dermatitis, eczema rash, and urticaria on the skin, and other side effects such as trauma, influenza, hypersensitivity reactions. The nurse administering the medication, Montelukast, must be aware that it must not be given to those that are hypersensitive to the drug or its components, as well as individuals that are having an acute asthmatic attack or status asthmaticus. It must be used cautiously in Peter if he has a history of liver disease or if he has consumed alcohol due to the presence of a special day. Furthermore, the drug must not be used as a substitute for inhaled or oral corticosteroids. The nurse must ensure that the medication is not abruptly stopped or reduced unless it is indicated by a medical specialist such as a doctor. And finally, the result of the effectiveness of the medication must be monitored in Peter.
The next medication that was prescribed to Peter was the selective long-acting beta-2 adrenoreceptor antagonist, salmeterol. It is used as a controller medication for long-term management of reversible airway construction in asthma, COPD, and exercise-induced asthma. The one that we prescribed to Peter was the 25 microgram inhalation metered dose inhaler, but it is also available in a 50 microgram blaster acute beta. So the action is to open the airways of the lungs, making it easier to breathe. The dosage for it is the 2 to 4 inhalations of 50 to 100 micrograms twice daily. The side effects are muscle trembles, mostly the hands, tachycardia, nervousness, headaches, peripheral dilation. The interactions: it has a risk of increased arrhythmia if given with digoxin or other cardioglycosides. It can increase blood glucose and blood pressure levels. Combined with nebulized salbutamol and ibuprofen can result in closed angle glaucoma. The nursing considerations: always checking vital signs regularly, monitoring for any cardiac arrhythmia. Since Peter also is prescribed fluticasone, it is recommended to be taken approximately 10 minutes after the use of salmeterol or salbutamol. The cautions: should not be used for acute asthma or acute exercise-induced asthma, as it is required for long-term use. The patient education: we should advise Peter to take small doses early in attack before it becomes severe, and warn Peter of the side effects and the correct way to use the inhaler.
It is an oral inhaler plus a class of bronchodilator. The usual dose of this medicine is 2 mg or 4 mg 2 to 4 times a day. Nursing consideration: monitor for the pulmonary function, blood pressure, level of potassium in the blood. Patient education: avoid allergens, irritants. Teach to use the peak flow method or report if anything is worsened. Cautions: before administering the dose, check for any cardiac problem, seizure, low potassium level. Use in pregnancy when it is clearly needed only. Overall action: prevent and treat wheezing and short of breath. It is also used to prevent asthma attack brought on by exercise. Overall use: controlling symptoms of breathing problems, relaxing muscles. Side effect: nervousness, shaking, mouth or throat irritation, cough, headache, trouble sleeping. Interaction: avoid taking MAO inhibitor, example, isocarboxide, monoamide, procarbazine, tranilpromine within 2 weeks before, during, or after treatment with this medication.
So I'll be talking about the inhaled corticosteroid fluticasone propionate. Available forms of this drug include a nebulizer suspension, a junior inhaler, a metered-dose inhaler, and as an adult and junior dry powder inhaler. The actions of the drug include reduces swelling and irritation in the walls of lungs, reduces inflammatory reactions in airways, in the ultimate goal of easing breathing problems and preventing asthma attacks. The use of the drug is as a preventer prophylactic medication, which is usually used as a part of a general plan in managing asthma. The average dose for adults is between 100 to 1,000 micrograms twice daily, and for children is between 50 to 100 micrograms twice daily. Common side effects include a sore throat or tongue, hoarseness, throat irritation, rounded face, loss of bone density, eye problems, slowed growth in children, soreness in esophagus, paradoxical bronchospasm, pneumonia in chronic obstructive pulmonary disease patient. Interactions of the drug should not be used in patients that have an allergy to fluticasone propionate, lactose, or milk protein. There are reports of increased blood glucose levels in patients with histories of diabetes. Combination with ritonavir can cause plasma concentration of the drug to increase, as well as the combination with ketoconazole can increase systemic exposure to fluticasone. Considerations of the drug: the care and hygiene of mouth and throat due to the common side effect of throat or tongue irritation, monitoring of patient vital signs, work of breathing, and lung function tests, monitoring of growth in children and adolescents as the medication may slow growth. If patients experience oral or throat irritation, rinsing mouth after using the inhaler may provide relief. Cautions of this drug include that it should not be used to treat attacks of breathlessness, as this drug is not a reliever medication, and the possible development of pneumonia in patients with chronic obstructive pulmonary disease. Patient education with this drug involves explaining the difference between a preventer and reliever medication, demonstrate correct use of the inhaler, and advise patients of the plethora of side effects that may occur.
As the patient have very abnormal vital signs, so the vital sign must be taken at interval of 15 minutes until there is something stable or normal range is showing up. The oxygen concentration is 75, which is way too less. Even a patient with respiratory problems should have an oxygen concentration of 88 to 90. The patient is not even in his sense, so that he could try the deep breathing or coughing method to see if there is any alteration in the oxygen level in the blood. And the most important is we go for a medical, as we need for a team member to assist us to manage the situation. An immediate X-ray is needed to see if there is any collapsing in the alveoli or the respiratory tract. It will also help to visualize if any mucus or other surfactant is interfering with the task of the lung. Surely it is an asthma attack. In this case, spirometer is very important. Spirometer is a mechanical device to measure the volume of air we inhale or exhale or the residual volume in the lung. Therefore, the entire physiology of the lung can be monitored using the spirometer. We need to check for health history. Check whether or not he had suffered from asthma attack previously. How severe was that? How frequently does he have an asthma attack? How was the previous attack managed? What were the intervention and care plan, and what were the medication? Does he have any other underlying condition that must be taken into consideration before actually planning a care plan or getting out of this emergency situation? Check for the medication to see what are the medication he has been prescribed, what are the few medicine he has been prescribed for the emergency situation, and is he allergic to any sort of medication. Blood tests can also be done to see if there is an lactic acid accumulation in the blood due to the lack of oxygen, or to check for the potassium level in the blood.
So I'll be continuing the nursing management. So the first one is oxygen therapy. So managing acute asthma in clinical settings can involve oxygen therapy with the goal of achieving 92 to 95% oxygen saturation in adults. To achieve this, the nurse should think about the choice of oxygen delivery device, the flow rates, and the fractional inspiration of oxygen. Continually reassessing oxygen saturation using a pulse oximeter or conducting blood gas analyses before and after each intervention. Oxygen delivery devices include nasal cannula, which usually operates at a flow rate of 0.5 to 4 liters per minute. There's also the Hudson mask, which operates at 5 to 12 liters per minute. And there's also the non-rebreather mask, which operates between 10 to 15 liters per minute. So then we have the exacerbation treatment. So in accordance with the asthma handbook figure, managing acute asthma in adults, in mild exacerbations of asthma, the nurse should consider giving 4 to 12 puffs of salbutamol with a spacer. In severe exacerbation, if a patient cannot breathe through a spacer, consider intermittent nebulizer use with salbutamol and then starting oxygen. In life-threatening situations, continual nebulizer use with salbutamol is recommended. Oxygen should then be commenced. So we also have lung auscultation and observations. So common symptoms of patients with exercise-induced bronchoconstriction, which is often caused by asthma, includes coughing, wheezing, shortness of breath, chest pain, and tightness. As such, it would be appropriate to regularly observe the patient and conduct lung auscultations. During lung auscultation, wheezes should most likely be heard as they are typically present in obstructive airway diseases such as asthma and usually indicates the narrowing of airways. If abnormal sounds are auscultated, such as crackles, it would be important to document and inform the nurse in charge or doctor that these sounds may indicate further respiratory condition or disease. So finally we have an asthma management plan or action plan. Asthma action plans are considered an integral part of asthma management by the National Asthma Council Australia. The asthma action plan contains specific information to help the person with asthma and/or carers take early action in the event of an asthma attack. The asthma action plan is written together with the patient, doctor, and if applicable, the patient's carer. The nurse can also be involved in the development of an asthma action plan by initiating the creation of the plan, providing suggestion, and raising concern to any of the key points of documentation that might have been missed. Asthma action plans should generally include basic details of the patient, doctor's contact, carer and/or emergency contact person, maintenance preventer therapy, such as the names, doses, and frequencies of regular medications. Should also be information to recognize asthma exacerbations and how to respond to these exacerbations. And finally, there should also be a managing of severity and a call when to seek urgent medical help.
National Safety and Quality Health Service Standards. Standard 1, Governance for Safety and Quality in Health Service Organizations. It is essential for patients to be receiving adequate amount of care in healthcare services. By doing certain actions like health hygiene, getting consent for care given, and always confirming the patient to the wristband or information would help improve the quality of care given and also help the conditions of patients. For our patient Peter, it is important he is given reasonable care for his respiratory system more than any other systems in his body. Standard 2, Partnering with consumers. It is critical for nurses to communicate with patients when it comes down to care plans, medications, and any information that can be provided from the patient for their speedy recovery. Communicating with patients allows nurses to find out any insignificant information, and it allows the patient to be comfortable to be able to share this information. For our patient Peter, getting information on how he usually copes with his asthma attacks in the past would help the nurses create an individualized care plan that is suitable for him and for future references. Standard 4, Medication Safety. Using the 7 rights of medication and identifying that it is the right patient would determine that the medications for the right
person and is not given to another patient by mistake. This will decrease the risk of conditions deteriorating, and it is important that Peter is given the correct dose and medication for his asthma condition, as incorrect medication could lead to another asthma attack. Standard 6. Clinical handover. It is important that clinical handover notes are up to date with patient's condition. Lacking of information can lead to a severe adverse event which could be preventable. Within the handover notes, it is essential that Peter's condition is updated regularly, especially on his vital signs, as it would indicate whether he is improving or deteriorating. Standard 9. Recognizing and responding to clinical deterioration in acute healthcare. It is the nurse's responsibility to maintain regular checkups of patients in the ward by checking their vital signs and determining whether the patient is improving or deteriorating, or needs immediate help before the condition escalates. Regular checkups and vital signs on Peter would be a priority as he has difficulty breathing. If there is any indication of his condition worsening, it is important for the nurse to follow his asthma care plan or to stabilize Peter before it becomes severe.